This is our fourth webinar this week, and I'm really happy that we are exploring so many different topics. And today, this is a topic that some of you are probably already familiar, as this is about PGT A. But of course, we have a special guest to explain how it works, and this will be a little bit from a different perspective, I think, as well, which is great to explore for sure. And as you can see, Claire Bascuñana is with us. So hello, Claire. Welcome. This is your first webinar with my IVF. Welcome to our platform. Glad that you joined us today, and you will discuss this topic from your perspective. And let me just remind everyone that Claire is actually a genetic counselor, so this will be her perspective on PGT A. She's doing the consultations on daily basis, so I'm sure she's great to support you, answer any of your questions. Hi, Claire. Good to have you here. How are you?
I'm fine. Thank you for the introduction. I'm glad to present with you today.
We are definitely happy to have you. We are connecting with Canada right now, Montreal, I'm right?
Exactly.
so this is 2 p.m. for you. It's already 7 p.m. for us here. So thank you for agreeing to join us today. And let me just briefly explain that we will start with Claire's presentation on our topic. But afterwards, as I've mentioned, Claire is here for you. So if you have any questions, you know what to do. Type those in the chat. Claire will be happy to answer them for you. I'm sure of it. And of course, remember, it's all anonymous, so feel free to share anything you wish to share with Claire, and I'm sure she'll be able to help you out a bit. And this is recorded as well, so don't forget that. But I guess we can now move on to our presentation. Ready, Claire?
Yes, I cannot see my presentation.
Here it is. Sorry.
Okay,
Perfect. So don't worry, everything is working.
That's perfect. So I guess everybody's seeing the presentation now. So I'm gonna start. So thank you for the nice introduction. So as Caroline said, I'm a genetic counselor. I'm from France, but I'm working in Canada currently, and I'm certified in Canada. And today I'm gonna talk about PGT-A, and for sure I know a lot of you already know a lot of things from PGT-A. But what I expect today is to try to give my little perspective as a genetic counselor. So I hope it's going to help you through your journey. And as Caroline said, if you have any question at the end of the talk, or if you want to reach out after the talk, I will be glad to help you the best I can. So I will start. A lot of things you may already know. If you have any question, of course, you will feel free to ask at the end. So just to begin, for those that are not aware of what is PGT-A, it's kind of an add-on on IVF cycle that you can have, which is a pre-implantation genetic testing for aneuploidy. So it means it's a testing before the implantation on the embryos. And the objective of the testing is to look at aneuploidy, which is an abnormal number of chromosomes. So for those that are not really used to hear these terms, we are supposed to have 2 copies of each chromosomes, and when there is an extra copy of chromosome or a missing copy of chromosome, it can have impacts on the development, on the pregnancy, and on the health. So the fact to have abnormal number of chromosomes is an important determinant for fertility success, if I can say so. So that's the reason why PGT-A is used to screen for aneuploidy. So I will try to use abnormal number of chromosomes, but if you hear me use aneuploidy, it means that there is not the good number, or the good expected number of chromosomes in the cells. So why PGT-A is used? The objective initially of having PGT-A would be to increase the implantation rate per embryo transfer during an IVF cycle. It means that we want to increase the likelihood after the transfer of embryo that it gives an ongoing pregnancy. The second thing that is supposed to do is to decrease the likelihood of losing the pregnancy, of a miscarriage. And this is also per embryo transfer. It's like for each transfer, we want to reduce the risk that the pregnancy is not going to term and it's interrupted like in the first weeks. And it's also aimed to decrease the time before to get an ongoing pregnancy, especially if during the IVF cycle, there is a large number of embryos that are produced. As you can imagine, the more embryo you have, the more possibility you have to transfer. But then if you do not transfer first the one that have the best likelihood to give an ongoing pregnancy, you may may take more time before to be pregnant. So the PGT-A aim to reduce this timing by directly selecting the embryo or the embryos that have the best likelihood to give an ongoing pregnancy. And all of those objective is to increase like the efficiency of the IVF if we compare to the standard method, which is just to look at the morphology of the embryo for selection. And we know now that a good looking embryo with good morphology is not enough to make sure that this embryo is going to be viable. And we know that sometimes a very good looking embryo with good grade is actually going to have chromosomal issues that are not compatible with life. So that's the main reason why PGT-A was like implemented in fertility clinic in the IVF cycles. It's important to understand the link in the association between the aneuploidy, so the chromosomal issues, and the maternal age. We know that with increase of the maternal age, there is more and more increase of the proportion of abnormal embryo produced. And you can see here in the little graph that the more the age increase for the woman, the more the proportion of embryo with abnormal chromosomes is increasing as well. And as you can see, at 36 years old, it's actually half of the embryo produced that are going to be euploid, so with good number of chromosomes, and half of the embryo that are going to be with chromosomal issue. So we see that there is really a big impact of the maternal age. And what we know also is that aneuploidy is one of the main cause of implantation failure and miscarriages. So with that, you understand why PGT-A could be useful to improve those factors. And as we said, like the morphology alone of the embryo is not sufficient to determine if there is chromosome issue or not on the embryos. So with that, you can understand that there is specific population of patients that can benefit from the PGT-A. What was studied in the literature is that not all patients could benefit from PGT-A. It's not something that could be useful for any type of patient. It's important to keep that in mind. It's not the perfect option for everybody. The first population of patients that could benefit from it, it's patients with advanced maternal age. So as we saw on the little graphic before, like patients with maternal age advanced have more risk to produce abnormal embryo. And the fact to have abnormal embryo means that you are less likely to have an ongoing pregnancy because of the chromosomal issue. So for those women, the PGT-A would allow to select directly the few embryos that are not affected with chromosomal issue and to allow to have an ongoing pregnancy. And the two other patient population that could benefit significantly from the PGT-A would be the patient with a recurrent issue of miscarriages or implantation failure. For those two categories of patients, it's important to keep in mind that if the miscarriage or the implantation failure are not due to chromosomal issue, if there is other health factor involved, the PGT-A is not going to help. The PGT-A is going to reduce the miscarriage risk and the implantation failure risk if those issues are associated with chromosomal problem. And sometimes we don't know. So we try to add PGT-A to a cycle to see if it can help. And sometimes even with PGT-A, you can still have implantation failure or miscarriages. And it would mean that maybe the reason for the miscarriage or the implantation failure is not the chromosomes, but something else that needs to be investigated. So it's not a perfect test. And so for the woman with advanced maternal age, what we say is that the PGT-A seems to eliminate the effect of the maternal age on the implantation, but it does not influence significantly the outcomes for young patients with good prognosis. So if you do not enter in those category of patients, you may not benefit from the PGT-A, and actually it could sometimes be harmful, and I will explain how, because I'm going to explain the limits at the end of the talk. So for the PGT-A, many of you know exactly how it goes, but I'm just going to go back a little over the process just to make sure that it's clear for everybody. So as you know, so it's an add-on for IVF. So to do PGT-A, you need to do IVF. Most of the time, it's more you need to do IVF, and we offer options to add the PGT-A to the IVF. You know how the IVF is done. We need hormonal stimulation, a function of the ovocytes, and a sperm preparation. Regarding the intracytoplasmic sperm injection, is just a specific method that we use for IVF instead of just exposing the sperm to the ovocyte. And it's a way to ensure when we do PGTA to have a monospermic fecundation, meaning that we just take one sperm to one ovocyte. We don't want to have any contamination. So it's like recommended to do this specific technique for the PGTA. Some studies were mentioning that the use of this intracytoplasmic sperm injection could be harmful and increase the risk for certain type of anomaly. But it was really hard to have a consensus between the studies. And some studies were saying that it's more like the reason of why we do this technique, more of the technique by itself that could increase the risk, knowing that this technique is mainly used usually for the male factor infertility. So this is still controversial. For the in vitro fertilization, it's important to know that based on the pool of ovocytes that's going to be collected, not all of the ovocytes are going to be fertilized. We think that always 60-70% of ovocytes only are going to be fertilized. So we lose at each step of the process a little of the biological materials, and we're going to get a certain number of embryos at the beginning of the developments. After the fertilization, we wait several days before to have the biopsy. So we have the embryo that is developing each day until the day 5. The day 5 is what we call the blastocyst stage. You may have heard about it. The day 5 is the stage where the blastocysts look like that, with an internal cavity, one mass of cells that are the future cells of the fetus, and one mass of one layer of cells around. It's the future placenta. And at the time of the biopsy, already 50% of the blastocytes are going to survive, meaning that you lose already 50% of the embryo because of just like a kind of survival, natural selection. The biopsy of the embryo at day 5 needs a good expertise, and all the studies, when it's done by an expert lab, show similar pregnancy rate with or without biopsy. So the biopsy by itself does not seem to harm the future development of this embryo. During the biopsy, only 5 to 8 cells are biopsied, not a lot. It's an embryo that maybe has 100 cells at this stage of the development. And oh yeah, I was saying that. So the cells that are collected during the biopsy, as you can see, are not the cells of the inner cell mass. So are not the cells of the future fetus. It's definitely the cell of the future placenta coming from the layer that we call trophectoderm. So right now, from here, you can understand why the PGTA cannot be a perfect technique. It's not 100% reliable because the cells that we analyzed for the biopsy and for the PGTA are not the ones that are going to give the future fetus, are the ones that are going to give the future placenta. Most of the time, the cells from the future fetus and from the future placenta are the same, with the same chromosomal and genetic content. But sometimes it's different. And when it's different, we can have discordance between the result of the PGTA and the status of the future fetus. And this we're going to discuss is the concept of mosaic. I'm going to explain that a little later. So after like the biopsy, the cells that are biopsied from the embryo are sent to the PGT lab, and the embryo are frozen at the fertility clinic and waiting for the result. The point is to freeze all the embryo, to send the biopsy to lab, and then when we decide which embryo is the more likely to give a healthy pregnancy, we're going to choose the best likely, the best embryo possible of this cycle, and we're going to thaw this embryo for transfer. Regarding the genetic analysis by itself, so the PGTA by itself, what it is. So this preimplantation genetic testing is usually performed by a technique that we call next generation sequencing. The objective of the test is simply to look to see how many copies of each chromosomes the biopsy cells has. We want to see if each chromosome is present in 2 copies. We are supposed to have 2 copies, one from the biological mother, one from the biological father. When we have more copy or less copy, we call that trisomy or monotony. This, we know, impacts the development of the embryo and the health of the future pregnancy if there is a pregnancy. This technique of PGT-A can look at a lot of things, not only the big, like the whole extra or missing copy of chromosomes, but some parts of abnormal chromosome as well that we call segmental aneuploidy. A segmental aneuploidy, by opposition to a whole chromosome aneuploidy, is when there is just one piece of the chromosome that is missing or duplicated. But the PGT-A does not look if there is microduplication or microdeletion. When it's small pieces of chromosome, it cannot be detected by the PGT-A. It's only the whole chromosome or big pieces of chromosome that can be detected here. And you can see here with the little like drawing, but like a segmental anomaly is when just like a piece of one arm, for example, of the chromosome would be missing. So this is what the PGT-A is looking at. Important thing, again, PGT-A is not 100% accurate. You remember what we said. This information regarding chromosomes is based on future placenta cells. So it does not tell us what is the status for the future fetus cells. So that's why for each PGT-A done, even if the PGT-A is telling you that your embryo does not have any chromosomal issue, there is still prenatal recommendation because it's not 100%. So it's not a diagnostic test. It looks more like a screening of the embryo at the end of it. When we thought about like PGT-A results, most of the time patients think that is either we transfer or we not transfer, like a yes or no answer, but it's much more complicated than that. So PGT-A result can have different type of impact. Yes, definitely, we want to know, can we transfer or not this embryo? But we also want to know what would be the priority order of those embryos. If you have like many embryo, you test many embryo, you don't want to just know yes or no. You want to start with the best likely, the more likely to give a healthy pregnancy. And then, depending on the status of the result, it's going to help you to evaluate what is the likelihood of actually being pregnant after the transfer of each embryo, and what would be the recommendation for prenatal screening, depending what type of embryo you transfer. Because if you transfer what we call an euploid embryo without any chromosomal issue, it's not going to be the same recommendation that if you transfer like what we call a mosaic embryo with some specific recommendation that can be recommended in this situation. So the PGT-A result is not yes or no and should be discussed ideally with a genetic counselor or with your doctor to understand really the impact of each type of result. For the genetic analysis, important to know for you, when your clinic is sending the cells to a lab, it's important to know that all the different labs doing PGT does not work exactly the same. Each lab is going to have a specific threshold to determine if an embryo is euploid, aneuploid, or mosaic, depending of like the threshold they put. And we know that a lot of studies came saying that depending of the lab, we don't find exactly the same result for the same embryo. So it's important to keep in mind that the lab by itself can influence the type of result you can get. And about that, for years, mosaicism, so the fact to have a mix of cells like normal cells and abnormal cells, was not reported by a lot of labs, because we were thinking when there is some abnormal cells, we're going to just discard those embryo and name them aneuploid, so abnormal. More and more now, we advocate for the fact that those embryos can be transferred with proper genetic counseling and proper prenatal care. And it's now important for patients when they do a cycle, even if you did a cycle a few years ago, to ask to the clinic to get the result, to make sure that the lab can report this threshold to see if some of the embryo that were called abnormal or aneuploid at this time could not be actually mosaic and could be actually transferred for some patients that were thinking that it's over and they do not have any more embryo to transfer. So it's very important information to ask your clinic before to start a new cycle or to discard embryo, of course. So for the result, the type of result you can have, first type of result, it's not on the slide, but it's just inconclusive result. When the test did not function it, like it didn't work, you don't have any result. And then the only thing you can do for this embryo that is tested without any result is to assume the likelihood of ongoing pregnancy based on the maternal age only, with the little graphics I show you at the beginning to estimate. The other result you can have, depending on the lab, because certain lab does not report mosaicism, but now most of them are, it's euploid, mosaic, and aneuploid. So euploid, as you can see here, it does not mean that your embryo does not have any abnormal cells. Even when the lab reports euploid, meaning normal embryo, you can still have up to 30% of abnormal cells in the biopsy. But below this threshold is considered like normal. Then the same thing for aneuploid, for abnormal. Depending on the lab, the threshold can vary, but it means like for certain laboratory, if you have more than 70% of abnormal cells, the embryo is going to be called aneuploid, or the biopsy at least, it's going to be called aneuploid. And in most of the fertility clinics, they won't allow the transfer of aneuploid embryo. Certain clinic in specific country can allow it. It's really clinic dependent. Why it's not allowed most of the time? It's because it was shown in studies that when there is more than a certain percentage of abnormal cells, the likelihood of getting a pregnancy is very low. Some studies say that it's less than 10%, maybe 7% of actually implantation rate after abnormal embryo transfer. So it's not impossible, but it's very not likely to have a healthy pregnancy with the transfer of an abnormal aneuploid embryo, truly aneuploid. And the third category that is actually the more complex and the more gray zone, and that is raising a lot of questions into the fertility field, are the mosaic embryo. So the mosaic embryo, as you understand now, it's all between, let's say, 30 and 17% of abnormal cells. So mosaic embryo means that you have a mix of normal cells and abnormal cells. And actually, the fact to have a mix of normal and abnormal cells is something that is physiological. We know that it exists at the first steps of the embryologic development. And this phenomenon is actually the basis of why there is sometimes discordance in the PGT A results. It could be false positive, it could be false negative. When we talk about false positive, what it means? It means that sometimes we could say an embryo is abnormal based on an abnormal biopsy, but finally the fetal cell would be normal. In this situation of a false positive, we may actually discard an embryo that is good and could have led to a healthy pregnancy. For the false negative, it's the opposite, is when we say, it's okay, the cell in the biopsy are good, there is no chromosomal issue, and we transfer this embryo, but at the end, finally, the fetal cells were affected with chromosomal abnormality, and at this time, it will give either like an implantation failure or a miscarriage, or sometimes a baby affected with a chromosomal diagnosis. So these false positive and false negative are not frequent, but are still existing to the PGT-As. Most of the time we have accordance between the result and the status of the fetus, but sometimes we have a discordance. And for the mosaic embryo, there is a lot of studies about that. What was shown in the studies that is, if there is a good proportion of normal cells and not a lot of abnormal cells into the biopsy, we were thinking that there is a possibility of self-correction, that the embryo could self-correct by giving at the end a healthy euploid fetus, meaning like a fetus with proper number of chromosomes, even if there is some cell into the PGT-A biopsy that has some chromosomal defects. And what we see as well is that the percentage of the mosaic is a very important factor. So the more percentage of mosaic abnormal we have, the less likely the embryo could self-correct. And what it means is that when you have a low number of mosaic cells with chromosomal issue, actually we see a low concordance of the result. What it means is that a lot of those embryos that were called mosaic embryo based on the PGT-A are actually going to be euploid pregnancy at the end, meaning that a lot of those can be transferred and give a good chance to have a healthy baby at the end. So that's the messages that you could keep in mind, is that some of the low mosaic embryo have good chance to give healthy pregnancy at a similar rate as euploid embryo, depending on the percentage of cells that are in the mosaic. For this, I'm going to pass because it's a little complicated and I see the time, so I'm going to pass a little more. I want to discuss a little more about the outcomes of the mosaic embryo transfer. So as I said, now all the clinic try to report this data to the patient to help patient decide. If you do a cycle and you have a lot of euploid embryo, like normal embryo, it's good. You don't have to think about it. But some patients, they do cycle, and at the end of the cycle, they just have mosaic embryo or aneuploid embryo, and they want to see if they have a chance to be pregnant without to do a full other cycle. So yes, globally, we know that mosaic embryo have less implantation rate and increased rate of miscarriages globally with the mosaic embryo. We know that the low mosaic embryo could have similar ongoing pregnancy rate depending on the percentage compared to the euploid embryo. And the recent studies regarding the risk when you transfer a mosaic embryo to have actually an affected pregnancy, meaning you transfer the mosaic embryo, you are pregnant, you do some prenatal diagnosis, and finally your fetus have a mosaic chromosomal issue that can affect his life, would be around 1%. And this is based on recent study of like 3,000 mosaic embryo transferred, and that's what we thought we found, like 1% risk to have an actual abnormal prenatal diagnosis once the pregnancy is ongoing. And new studies also said that there is some follow-up that have been done for the embryo, mosaic embryo transferred, and at 3 years old, so after the transfer, they were seeing no significant difference between the pregnancy complication, the type of delivery, the birth at the age of delivery, the Apgar score at the birth, and also the congenital anomaly and the chronic illness at 3 years old. So it's very encouraging that we should let patients decide if they want to use mosaic embryo when they have and when they don't have like normal euploid embryo to transfer. So if we go back to the different type of result, depending of the type of result, we're going to estimate the likelihood to have ongoing pregnancy, and it's going to depend of the status of the PGT result and on the low or high level of the percentage of mosaic if it's for a mosaic embryo. And as you can see, even for a normal euploid embryo, the likelihood to have a pregnancy is not 100%, and there is still a possibility to have implantation failure even after the transfer of an euploid embryo, because you can have other reasons like something associated with the endometrium, immunological, hormonal, other type of factors that can be involved. So another thing that is important, sometimes depending of the clinic or where you are followed, your doctor can just tell you, oh, you just have abnormal PGT A embryo, like a result of your embryo at the PGT A. It's important to know that abnormal PGT A could mean a lot of different things. Sometimes is you don't have any results. Sometimes it's you have a chaotic result with 6 different types of anomaly. Sometimes you have a mosaic that is identified. Sometimes you just have like what we call the segmental aneuploidy, meaning just have one part of the chromosome that is missing. Sometimes it's the whole chromosome missing. All these specific situations, I don't have the time to detail now, but should be addressed by a genetic counselor if you have hesitation of if you can transfer or not those embryo. Of course, depending of the policy of the clinic, you have to adapt to the policy, but just to ask those questions could be really helpful for you to feel empowered through your fertility journey and to know exactly what those results mean. And another thing to think about is sometimes some clinics are very worried at the idea to transfer, for example, a mosaic embryo. But before PGT-A, and if you don't do PGT-A, we transfer blindly thousands of embryos that are probably mosaic or aneuploid without knowing it. And so it's just like something we need to think about when we like forbid the patient to use certain of their embryo. So now we talk about the type of result. The next step after receiving the result and deciding which embryo should be transferred is the transfer of the embryo. 99% of the embryos survive at the thawing, and then we expect an implantation rate would depend of the embryo status. And depending of this embryo status, we're going to have specific prenatal recommendation. So globally, when you transfer a euploid embryo or actually in a euploid biopsy of the embryo through PGT-A, what is recommended is to still have all the ultrasound, like the first trimester ultrasound, ideally with a nuchal translucency and the morphological ultrasound. Regarding specific prenatal screening, it's important to know that PGT A have a similar detection rate as fetal DNA testing, like NIPT or non-invasive prenatal testing, depending how you call it. So because of that, it's said that it's not recommended to do like the serum marker screening because it's less good in terms of detection rate than is the PGT-A. So that's the first thing. For the patient that still want to have an additional screening, they can go private to have access to the non-invasive prenatal testing, but it's not fully necessary as the detection rate would be similar of what was done pre-implantation with the PGT-A. For the mosaic embryo that are transferred, of course, the ultrasound are still indicated and it's still possible to go through any type of screening. But most of the non-invasive prenatal screening are looking only at the main chromosomes, 21, 18, and 13, that are possibly viable during a pregnancy. And sometimes the type of mosaic that you transfer is affecting another type of chromosome, let's say chromosome 2, that is not looked at the screening. So because of that, for all pregnancy issued from mosaic embryo transfer, there is a possibility to go through amniocentesis, like invasive prenatal diagnosis, to target the specific chromosome of the mosaic and make sure that the fetus is not affected. I put back again the 1% risk that is actually right now like the estimation of the risk of having an abnormal prenatal diagnosis following a mosaic embryo transfer. And I would say that from the recent study, a lot of patients, because it's very valuable pregnancies, they don't want to go through the invasive testing, even with the 1% risk, and it's totally like a personal choice and it's totally fine. So now I'm going to finish with the limit of PGT-A and some take-home messages, and then I will be available for your question. So the limits of PGT-A. First one is that it does not improve the cumulative success of your cycle. It's not changing the success of your cycle. It's only impacting the success per transfer. That's the only thing we can improve with the PGT-A. Same thing, it cannot guarantee anything. It's not guaranteeing to have embryo to transfer. If all the embryo produced in a cycle are aneuploid, you may not have any embryo to transfer, and PGT-A cannot do anything about that. As I already said, the PGT-A could have no benefits, could delay a pregnancy because you wait for the result of the testing, and could discard viable embryos because of the possible false positive and false negative result. So there is no proven benefits right now for PGT-A for young patients without any relevant history. Another thing important to keep in mind is PGT-A does not guarantee the birth of a healthy kid. The PGT-A is only looking at chromosomal issue. It does not screen for all the congenital defects. It does not screen for all the genetic conditions that are inherited. It does not screen for multifactorial disease, etc. So it means that even with PGT-A, you still need to have all the regular follow-up for prenatal care, like ultrasound, as I said, and it does not ruling out all the health issues that could affect a pregnancy. And the last thing is not giving 100% reliable result. As I said, there is possibility of discordance. So this does not mean that PGT-A is not good and you should not do it at all. It just means that for every test that you do, you need to understand the limit of the test. And the point of genetic counseling most of the time is just for you to make sure that you have an informed consent, that you know exactly for what you're going through, you know what type of result you can have, you know the implication of those results. And if you have questions, you know that you can ask the question to your team. So that is really important to understand. It's not something that you say yes or no without knowing the implication of it. And in specific situation, PGT-A is a very, very useful tool that can really help to have healthy pregnancy and to reduce the timing before to have those pregnancy. So I will finish with the take-home messages, and the first one is exactly what I said. A lot of things with the PGT-A is controversial, but it could definitely theoretically help with the speed, like the fact that you don't waste time to transfer abnormal embryo and you go directly with the one that have the best likelihood to succeed. As I said, if you're young with good prognosis, you may not benefit from it. And another thing that I didn't say before, but the decision to pursue with PGT-A could also be depending of the number of embryo you will get for each cycle. You can decide to have PGT-A and then you do a cycle and you just have 1 or 2 embryo produced. Maybe if you just have 2 embryo, you can just decide not doing the PGT-A and still try, you know, because you just have 2 embryo and it's not a lot to try to transfer. But it's really a personal decision at the end. don't hesitate to ask to your clinic relevant question regarding which type of PGT lab is used, and the policy regarding the mosaic embryo transfer before you choose the clinic where you want to be followed. It could influence the way that your fertility journey could be leading. And then knowing that genetic counseling should always be available. You should be able to ask to the fertility clinic you are to talk to a genetic counselor or someone that is specialized with this topic to help you manage to the priority of the embryo and the decision for transfer. This is something that could really be helpful during your journey. Last take-home messages. What is usually we say to the patient is like, until you feel that your family is complete, do not discard low mosaic embryo. You could decide to non-transfer them and do other cycle, but then you never know what you would get for the next cycle. And it's what we recommend is wait to the end of your family, like when the family is complete, before to discard like the low mosaic embryo, especially because research may be even more reassuring in a few years regarding those. As I said already, we know that there is possible discordance with PGT A, and prenatal screening is still indicated after the PGT A and depends of the results. So those were all the information I had for you today. I know that we still have some time for questions, so I'm going to stop there. If you want to reach me after this talk, you can reach me. I have an Instagram channel and a YouTube channel, and I have an email address. So if you have any question you want to ask me about something regarding like this topic, I will be glad to help you. So thank you for your attention.
Thank you so much, Claire. That was really interesting and thorough, for sure, explanation of PGT A, how it works, but also thank you for discussing the results. I think that sometimes it can be confusing for some patients, so thank you so much for bringing this up. And as you can see, there are some of the questions right here ready. And so if you have any other questions, now it's your time. We will start with the first question here. Let me just show you, of course, right. It's right here from Nina. Nina has a first question. So if I end up with one embryo, should I take the risk to perform PGT A on that one embryo? You've mentioned this during your presentation already.
Yeah, it's a super good question. And again, there is not good or bad answer. Like it's always personal choice. But as I said, when you just have one embryo, what we usually say, depending if it's your first cycle, depending your age and why you did the PGT and the IVF, it could be not beneficial to have to go through the PGT A and testing him if it's the only one you have. So if the only one you have, some people would say, go just transfer it, take a chance. Because if you test it and it's abnormal, you won't even transfer it, but maybe there is like this 5-6% of chance it would still work. So, you know, it's a personal decision, but for sure, it would be definitely something I would think about if there is just one embryo that is produced.
That makes sense, of course. Thank you so much for your question, and thank you for help with that. And of course, if you have any follow-ups, you know what to do. Sure, question. So how can we do PGT A on day 3 embryo?
So it's a good question. It was actually done at day 3 before. Like a few years ago, it was like the standard way to do it was to do it at day 3. What we found is like the biopsy at day 5 is better because there is less mosaicism. There is already a natural selection of the embryo because we know that half of the embryo are not surviving to day 5. And there is more cells, so it's doing less harm to the embryo. At day 3, there is much less cells. So that's why now most of the lab of the fertility clinic, I think it's a universe. It's not only in North America, it's everywhere, I guess in Europe as well. Everybody now is going on the day 5 biopsy. And I'm sure if there is specific, situation, they may be able technically to do it, but it's not like the standard currently are really day 5.
Okay. Thank you for the clarification. Let's have a look. We have a little bit of details here. So thanks for your talk. I'm 36, low ovarian reserve, only got 1 3 blastocysts per cycle. I've had 5 failed transfers from 3 cycles. Some doctors say never to do PGT A because we don't make many embryos. Some say we should because of recurrent implantation failure. We feel very conflicted and confused. We are worried about discarding a good embryo with some bad cells sampled.
Yeah, I understand. It's very difficult situation. So I would say in this situation, sometimes we can think at the PGT A as a way to better understand the situation. And what I will say to this patient is doing the PGT A, yes, there is a risk of discarding embryo based on the result that may be discordant, but there is also a way maybe to understand what is going on, okay? And sometimes doing the PGT A just be, okay, why my transfer are failing? Is it caused by chromosomal issue? Maybe it's not, but if you do PGT A and you look and you see that all your blastocytes are aneuploid with chromosomal issue, you may understand that the reason of the failure is chromosome. So it may help you even to investigate and to understand the reason why it's happening. But then, yes, you have this risk of maybe discarding an embryo that would have been transferred. So it's very tricky. It would be something that you need to discuss with your doctor because having 5 failed transfer could be an indication to look for PGT-A for the next cycle.
Again, thank you so much for your advice here. Let's have a look. More questions are coming in. So I have a high immunity which caused a 12-week miscarriage. The embryo is to be transferred next month and it's C1. C1, does that mean it's also been PGT-A tested?
I would not know. I'm sorry. I would not be sure. I think it's to be a very specific situation, so I would not know. We would need to ask if it was tested or not. Normally, it's something that you have consent to give for. So I would say that you should have signed to say, yes, I won't have to be done. It's not something that is done automatically most of the time. It's something that it's added.
Okay. If you have anything you wish to add, of course, you know what to do. Okay, let's have a look at the next question. So do you have any data about the percentage successful pregnancy or better the live birth after PGT-A euploid transfer? So maybe comparing with the non-PGT-A pregnancy or live birth. Right.
Yeah, I understand the question. So those are really clinic dependent, I would say. Like the data that I use, like the 60-70% were the one I was giving to the patient of the fertility clinic in Canada I was working in. So that the data that I was collecting from the clinic. So I would say those data is something that you can ask your doctor. Actually, your fertility doctor should be able to tell you in our clinic what our success rate, because it's quite specific. But to try to understand your question, maybe something you can do just like to estimate between the non-PGT-A and the PGT-A is mainly with the little graphic with the maternal age. What I'm doing with patients when they hesitate or when they want, for example, like an embryo that was tested, but it was not working, like it was, the result didn't work, is we look at the age. For example, for a young patient, an embryo that is not tested has a very good likelihood to be euploid and to give a healthy pregnancy. So it would not be the same at 30 as at 45, let's say. Okay, so depending the maternal age, that's why it's more indicated for advanced maternal age. It would be beneficial or not. And the live birth rate, non-PGT-A, does not exist for all patients. It's specific to maternal age and specific to situation. So I could look for a specific situation and compare, but it's not something that we can give like a global percentage for all the situations.
Of course. That makes sense again. I hope that helped as well, of course. Let's have a look. There is shorter question here. So amniocentesis isn't always recommended after PGT?
So again, in genetic counseling, we have one big principle, which is non-directivity. So for sure, there is some recommendation that say that it should be available. I would say that in Canada, the way it is, and I don't know exactly specifically in the different countries in Europe how it's done, but what we usually do is we give access for patients to amniocentesis, but specifically when the embryo transferred is found with a mosaic content. Yes. For the euploid PGT-A, I'm not aware of any recommendation in Canada that would say, do it. I know that in certain provinces in Canada, they give access to amniocentesis to any IVF patient. So it really can differ from different provinces and from different clinics. But globally, it's always a matter of balance between the benefit and the risk. And for the amniocentesis, because it's an invasive technique with risk of miscarriage, it's really a matter of how we estimate the risk of finding something with the amniocentesis versus the risk of harming the pregnancy. And this should be done, in my opinion, case by case.
Okay, again, thank you so much. I think it's clear as well. And let's have a look. Next one, it's not actually a question, but I think it's good to take a look at the comment from embryologist perspective. I believe that advanced maternity is the most risky group for PGT, mostly due to the quality of blastocysts developed, although indicated. I never recommend to perform biopsy procedure to a poor quality blastocyst due to high risk of degeneration. Although it is difficult to explain, this is our patients do not harm. Is our priority. Thanks for your presentation. Anything you can?
Exactly. Yeah. No, it's actually true. I didn't go into details, but I know in the clinic I was working is definitely we were first looking at the morphology of the embryo, and only the good grade embryo were biopsied. And for sure, I totally agree with this person. Like if we have a bad grade, for sure we won't like do any biopsy because we know like there is already a factor that is not looking good for the embryo. So I totally agree with this comment.
Thank you so much for your comment, and thank you for also addressing that. I think it's important to do that as well. One more question. So if you have more, this will be the final call for those questions. Yeah, there are some more. Okay, perfect.
They can reach me after, Benin.
Of course, we still can take this, I'm sure. So let's have a look. It's another interesting question that we receive quite a lot. So is PGT A recommended for egg donation treatment when the donor is less than 25?
There is absolutely no significant reason to recommend PGT in this situation because, as we said, if we have this age, like 25 years old, the proportion of embryo that we're going to get with chromosomal issue is expected to be low. And so there is not a definitive indication in this situation. I would not see why we would recommend it systematically. It would not make sense.
Mm-hmm. Okay. Thank you so much indeed for clarification once more. And one more question. So do you recommend PGT testing for a 33-year-old, no known illness who has had one cycle with 3 embryo transfer, all failed? Morphology were 4A and 3B, 3C.
It's super tricky to answer to a specific situation like that. In this situation, I understand that there is already 3 failure which could be considered as like a recurrent implantation failure, but it would be not to look only at the morphology, but to look at all the rest of the situation. So why this 33-year-old patient had IVF at the beginning? Was it more like a male factor, a female factor? I think we would need to have a little more of the background, the obstetrical history to make a decision because it's not crystal clear if it will be good or not in this situation. So we would need a little more information to make an answer for this one.
Excellent. Thank you so much indeed for that. And let's and of course remember, as always, if you wish to get some more details, you can get in touch with Claire. Of course, I'm sure she'll be able to help you a bit more, even more. So let's have a look at this question. So what do you think about batching to do PGT A? Is freeze-thaw risky?
Okay. So I'm not sure I understand perfectly because batching to do PGT. Yeah, no, okay. So what the embryologists of my team were always saying to me is that we try to decide at the time of the biopsy, which one we biopsy, which one we freeze that biopsy. Because what is not good, exactly what you mentioned, is to take an embryo, freeze it, unfreeze it, freeze it, unfreeze it. The more cycle you do, the less likely this embryo is to give a pregnancy. And at each thawing, we know that there is a 5% risk for the embryo to not survive. So I would definitely say that it's better to think about it on the first hand, depending on the number of embryo you produce after your cycle, then you decide how many embryo you want to do PGT on. Some patients, they have like 10 embryo, it's a good problem. They decide just to do PGT on 5 embryo. But then the ones that are not tested, it's rare that we really go back and do it. Technically we can, but it's decreasing the quality of the embryo to do those cycle of frozen and thawing.
Mm-hmm. Okay, again, thank you for explaining yet another question. Okay, and let me just have a look at the next one. Oh, sorry, we will go to this one because someone would like to get in touch with you. So let me go to the presentation. There is your email address right here. So the presentation will be available tomorrow, but of course, remember, I will copy this in a second, but remember, you can always also get in touch with me. I'll be happy to forward any questions to Claire. Okay. I will try to put this. Oh, maybe Claire, if you could perhaps put your email address in the chat so anyone can copy that.
Of course. How can I do that?
At the
I'm trying to find the chat. I'm sorry.
At the bottom, right? You should type your message right there.
I see all the messages, but I don't see where I can put my
At the bottom, can you, it's okay. I can copy that if you don't.
Okay, if you, yeah, I will let you
I will do that.
Sorry.
Not a problem at all. Okay, and I think we have one more question. So let me just go to this one. So does paternal age play a role in embryo quality? If so, would PGT A be recommended where the egg is from a young female less than 25, but where paternal age is advanced?
It's an excellent question. So paternal age definitely has a role into other type of genetic risk and on quality of the embryo for other type of factors. But for the chromosomal issue, the risk of aneuploidy is actually not associated with paternal age directly. So I would say that for paternal age, there is other things that would be recommended or to be taken in account, but PGT A specifically does not help with paternal age. The risk of genetic disease associated with paternal age is not chromosomal issue, but monogenic subtle like mutation, genetic mutation that cannot be screened on preimplantation genetic testing. Like they cannot be screened like all over the embryo.
Brilliant. Again, thank you so much indeed for this. And I believe that was our final question. But as you know, if you wish, you can always get in touch with Claire, and I'm sure she'll be able to help you even more, as I've mentioned. And before we finish, Claire, I would like you to see that there are many thank yous coming up your way.
Thank you.
There are some nice comments here for you as well, because I definitely agree. Just wanted to say a fantastic presentation. You explained everything so well. I have understood this the best in the last 4 years that I have been doing IVF. So thank you so much for that comment.
Thanks a lot. It's really a pleasure. So thank you a lot. And I'm really glad if I can help.
Definitely, it was really useful. I'm glad that we were able to discuss this and see your perspective on this. And of course, you've explained this very clearly. So thank you a lot for that. And I just want to add that stay tuned. Claire will be back with some other topics. So stay tuned. And okay, contact info. Yes, sorry. Let me go back to the presentation. This is, let me just put this in the chat and we will be finishing. And in the meantime, Claire, is there anything else you wish to simply add?
No, but if there is other topic associated with genetics that you want me to present for the next webinar, I'm still working on several topics, but I'm open to suggestions. So if you have anything that you want me to explain, I would be glad to use my genetic counselor perspective on
that.
Sure,
definitely. And of course, remember that if there are any topics that you wish to for us to discuss, please let us know. You can always email me and we'll be happy to take a look at some of your suggestions. We already took some of your suggestions this week, actually, during our previous webinar. So if there are anything that you think we could still discuss and you are interested in such topic, then let us know. We'll be happy to do that. And I guess that will be it for today. But thank you so much, everyone. That was really useful. The email address is in the chat, so you can use that. But as I mentioned, you can also go to Claire's YouTube channel and Instagram and find it there. Right now, I just want to invite you still, as we will be back on Monday, there will be another topic that we will discuss about failed cycles, miscarriages with Dr. Alexandra Eisler. So if you are interested in this topic, would like to ask some more questions, join us at 5 p.m. London time. We will be back on Monday. So thank you, everyone, for joining. Thank you for staying with us. And of course, I think it was a very informative session. Thank you, Claire, for being with us too. Looking forward to some more events with you, and take care. Have a good day, and everyone have a lovely evening as well. Bye.
Thank you. Bye-bye.